So I have Dr. Bridges Urology, on the stage with us. So we're going to talk about men's health, prostate cancer, BPH, and ED. So I'll start with prostate cancer. So when I was looking everything up, I saw that African American males are 60 to 80% times more likely to develop prostate cancer and 2 times more likely to die from prostate cancer due to late detection.
And see, that has been the problem for us. As we all know, early detection in almost any cancer state or disease of cancer gives a better outcome. Unfortunately, African Americans have been showing up diagnosed at a later stage, so our outcomes have been bad. To turn that tide around, I did a research study back when I was in the Army, comparing that to see if that was really true. People had equal access to health care, okay, in the Army. The survival rates were the same. So it appears to be more of a social economical reason as to why this happens. Also, education. What we have to start doing is educating people to understand you need to be evaluated, you need to be screened to see if you have prostate cancer or developing prostate cancer. If so, you picked up at an early stage, your prognosis is much, much better.
So at what age, so with the men here and everyone out watching, as a primary care doctor, right? I'm running in, I'm doing the hypertension, diabetes thing, and I may order a PSA yearly. But how effective are those screening tools, those little rip-off screening tools that the people come around and give to the doctors that we rarely ever use? Should the men here come in and ask their doctor to take that screening test?
Well, yeah. I recommend AUA guidelines that when you get to be 40 years of age, especially if you're African American, you need to start being examined and screened for prostate cancers. The screening test goes 2 ways. We not only do the blood test, the PSA, the normal range is 0 to 4, okay, but we also do a rectal exam, and most men will come in and won't come back for 2 or 3 years after their prostate is examined. So they said, Doc, don't you have a better way to do that? But those are the 2 basic screening tests. We also listen to symptoms. Men, as we age, will also all have symptoms of increasing bladder outlet obstruction. The same thing can happen with prostate cancer. So just having your symptoms stay the same, it's hard to differentiate. Is this cancer? Is this just BPH? BPH is the most common disease that most men will have. Symptoms of getting up at night.
And BPH is?
Benign prostatic hyperplasia, which is a benign growth in the prostate. People think my gland is swollen. It's not a swelling. Swelling indicates edema, fluid distension, but this is not what happens. It's actually a benign tumor that's growing in the prostate gland, okay? And this happens to all men starting around the age of 40, and it slowly increases. So if you come in at age 70, yeah, you're going to have some BPH, okay? Or you're going to have some prostate enlargement. The main thing is to differentiate, are you symptomatic enough to be on medications to help alleviate your bladder outlet obstructions, and which some of the symptoms, slow stream, hesitancy, urgency, urgent continence, getting up at night several times. These are some of the earlier symptoms of enlarged prostate gland. And when you have these symptoms, there are medications out there. Usually we start with things like alpha blockers to stop. You can also go to medicines that gear to shrink the prostate, like finasteride, Proscar, things of this nature. Sometimes we have to use the combinations of the 2. When the symptoms continue to increase, we may have to do surgical intervention. And there are different techniques that we use to alleviate the obstruction that the prostate is causing, okay? But the main thing is rule out, make sure there's no cancer in that.
So, like we said earlier, there's a whole plethora of things, a whole bunch of things over the counter that for increasing testosterone, prostate, all those. Like earlier, Dr. Warner educated us on St. John's wort making depression worse. Is there anything over the counter that you've seen that men should stay away from?
Well, first of all, these over-the-counter supplements and things, you have to be careful, especially when they're talking about they're going to boost men's health. First of all, you want to be screened to make sure you don't have cancer. So you go out there taking some of these testosterone precursors, it's like throwing kerosene on the fire. So before you start these things, make sure you get checked and there's no evidence or signs that there's prostate cancer going, okay? You also have to understand that most of these supplements, they're geared for one thing, as Dr. Green already said, they're geared to take money out of your pocket and put in their pockets. No scientific evidence that any of them work, and when we've done them against placebo, they don't even have as much effectiveness as the placebo effect. So a lot of these things are just out there, and people tout them as if there's some cure-all, and it's usually not, okay? So before you start taking the supplements, make sure you get screened adequately to make sure there's no prostate cancer going on. And then if you want to take the supplements, I don't have a problem with it. I mean, they got 50,000 supplements out there, and they're all geared for one thing, in my mind, is that's to take money out of your pocket.
So quick question. So you talked about pouring gasoline on a fire. So with testosterone, it doesn't cause prostate cancer, but if you have a small cancer there that might have been slow growing, the size of a pinhead, and you turn 80 and it may be a little bit larger. If you start taking testosterone and you have prostate cancer, is that going to accelerate the growth of that cancer?
And you're right. Testosterone does not cause prostate cancer, but anecdotally, it's when we have people with metastatic prostate cancer, the first thing we do is take away their male testosterone to slow the growth down. So it's kind of an oxymoron that, you know, it doesn't cause it, but it does not prevent it, and it may accelerate the growth. Taking testosterone supplements will also accelerate the growth of BPH. It may even make your PSA change, okay? So there's several things that you have to be aware of when you start hormone supplements, okay? And, you know, the question comes sometimes, a patient diagnosed with prostate cancer, he's been on hormone replacement therapy for years. When is it safe to restart his hormone replacement therapy? And I usually tell them a minimum of 2 to 3 years, showing that there's no evidence of recurrent disease.
Okay. And as far as prostate cancer treatment goes, you can have the prostate removed, there's seeding and radiation. Am I missing?
You're right. So treating prostate cancer depends basically upon the stage of your diagnosis. If it's a localized disease or has it moved beyond the prostate gland. If it's localized disease, then you're looking at either surgical removal, if you're a surgical candidate, or you're looking at radiation, which can be given one of two ways, external beam therapy or brachytherapy, which is seed implant. There's some other therapies out there, such as cryosurgery, HIFU, and these are more focal things that are really not at the cutting edge of treating prostate cancer, but they're things that can be done. Now, if the cancer has moved beyond the prostate gland, then you're looking at a more systemic approach in trying to control the disease using, and as I said earlier, hormonal ablation is the key here to start. We give injections like Lupron, Trelstar, basically shutting down the production of testosterone from the testicles. Also, we also have androgen blockaders such as Xtandi or Casodex, which block the androgen receptors so that the male hormones that are still in the body do not have access to the prostate cancer cells to stimulate them to grow. So, I mean, we don't want to get you at that stage. What we want is to pick you up early so we can get a great outcome. And with breast cancer, colon cancer, early detection makes a world of difference in the outcomes that our patient's going to get. So that's why the screening is quite important.
So, father, brother, uncles diagnosed with prostate cancer, we want to start at 40 anyway, but if they're in there, when should you start screening that individual before the age of 40?
If there's a super strong family history, you know, I've had a chance to take care of 3 families where every brother in that family had prostate cancer, father had prostate cancer. So if you got that kind of history, you probably want to start around 30, 35. At least get the PSA. You may not want to get the rectal exam, but at least get the PSA so you can have a baseline. We not only just look at the range of PSAs, but we look at rate of change of that PSA value. For example, if you come in, your PSA is 1, next year if you jumped up to 3, even though that's normal, I'm concerned. The rate of change is far too great, okay? So that's when you start looking at people to try to find out what's going on. Now, one of the diagnostic tools we use that has really helped us lately is not only the PSA digital exam, but an MRI of the prostate is starting to be cutting edge, where we can actually do a diagnostic study to see if there's any changes in the gland that's suspicious of prostate cancer. So a lot of guys come in before they just go straight to the biopsy because of increased or rate of change of PSA. We'll get an MRI of the prostate. If there's a high reading like a PIRADS 4, PIRADS 5, what we'll do then is take them into the hospital and do a targeted biopsy. In other words, we try to specifically isolate and locate this lesion in the gland that's suspicious of cancer. So things are really changing out there.
Yeah, and I just want to piggyback as well. Some people, you might have a primary care doctor that is actually looking at that rate of change. You go from, like you said, a 0.5 to a 1. If or the primary care doctor sees that your PSA is a 1, and they don't go back and check and see what it was the year before, and it was a 0.5. That increased by 2, right? Versus if you went from a 2 to a 3 or a 3 to a 4, and you're thinking, oh, I'm at the high end. That's not as dangerous as that 0.5 to that 1. You doubled in a year, So knowing your numbers and bringing that attention to you and ask questions of your primary care doctor. Well, what was my number last year? Should I be concerned? Because sometimes we see those normals and keep it going.
When we do diagnose prostate cancer, there's several things we use to try to help us define the best treatment plan for the patient. Of course, the biopsy, you get a Gleason score on the path report, either 6, it goes from 4 to 10. 4 being the slowest scoring cancer, 10 the most aggressive. The higher the Gleason score of your path on the path report, the more aggressive the prostate cancer is, okay? So it's also incumbent upon you not only to pick it up early, but to be aggressive with treatments. When people come in, especially my younger patients, I try to impress upon them that there's only one entity that's actually proven to cure you from prostate cancer: early detection and surgery. Radiation is given, and you're going to get a good outcome, but eventually, if you live long enough, the cancer is going to come back. So in my younger patients, I tend to push them towards surgery. Old people like myself, whatever you do, we probably can keep you around another 10 years, okay? Because with the treatments, usually prostate cancer is slow growing, but every now and then, we'll have one of those Gleason score 10s, and the patients just don't do well because of the aggressiveness of the cancer.
So, Dr. Bridges, you take my prostate from me, and I'm in my 30s. What does that do to me sexually? Having more kids?
Well, first of all, you probably won't be able to have children the old-fashioned way. When I say this, I have to laugh at myself because I used to tell people you're going to be infertile after your prostate cancer is treated. I had a patient that was 45, 46 when I did his prostatectomy. He later on got remarried, and his wife was younger, and they wanted to have children. So we sent them to an infertility specialist, and they actually took sperm from the epididymis and did an in vitro fertilization, and they have a beautiful little girl. So if you really want to be fertile afterwards, it can be done, okay, but you have to go to the extra step. As he was saying, when you have your surgery, some of the side effects, erectile dysfunction is one of them, and that's a big thing, urinary incontinence. So sometimes after surgeries, and let me say this back up, with the newer technique of the robotic prostatectomy, erectile dysfunction is becoming much less of an issue. We're able to isolate the neurovascular bundles as we do our dissection to get them out of the way. If you can preserve this neurovascular bundle, people will be potent, but they won't be able to have any children the old-fashioned way.
Okay. All right. And so, speaking of erectile dysfunction, I've been having a lot of patients coming in, and they're ordering this blue bag, this blue chew, or whatever it is, like off of the internet. And so what I've seen is it's just like lower doses of Cialis and Levitra. You want to kind of speak to that?
You know, when I first started practicing, there were gobs of things out there like the horny goat reed, red bones, everything you could name that people were selling at the stores to help with erections. Viagra came out, then followed by Cialis, Levitra. These are actually drugs that have been proven to actually improve blood flow to the genitalia, penis, okay? So they work. Now, people have piggybacked on that. Now they've gone generic, and everybody's got their own personal formulation. But if you start looking at the ingredients that's really working, it's going to either be sildenafil, vardenafil, or tadalafil, which are the PDE5s inhibitors that really help with erections. It's interesting when Dr. Green was talking, you know, it's, how do I say this? Everything about our bodies is intertwined. Now, when people come in to see me with just pure erectile dysfunction, what medical problems do you have? None. You need to go get your heart checked because there's a good chance you have underlying heart disease as well. You know, it's not like this segment of the body just decides to shut down and the vasculature is not working. It's happening throughout your whole body. So it becomes a systemic problem. So when I see the patients come in, that's all they're complaining of, denies any other things. You need to see your primary care doctor or see your cardiologist and be screened for cardiovascular disease too, because probably it's there and you're just ignoring symptoms.
And so with diabetic patients, we have to remind them that these medications work on blood flow. But if they're horrible diabetics and when we lose get neuropathy and when we lose this nerve innervation,
it doesn't work because there are guys who actually lose sensation in the glans penis. And when you do this, you lose the ability to be aroused, you lose the ability to have ejaculation, things like this. So, you know, we're all interconnected. The main thing, though, is keep your body healthy and strong. Go get your screening, get your checkups, exercise. You know, we forget a lot of times about, hey, you got to keep your weight down. You got to exercise. You got to do this, this, and this. And it becomes important for you to be active. Like you say, if you can't walk up a flight of stairs, you shouldn't be doing anything else. Like, you know what I'm saying? I mean, you got a bad heart. I mean, I can't fix that. Oh, I can tell stories, but I'm not going to tell stories up here that we got kids in the audience. But anyways, you know, your overall health is what's important. And just on look at one little micro aspect of your health, your mental health, your heart health, you know, everything's important to make you have a successful and enjoyable life. We can't just compartmentalize one little facet of our health and act like that's going to be everything. Think about your whole body and take care of your whole body. I mean, one thing, just take care of yourself. As they keep saying, you got to do the things that keep yourself healthy. And, you know, I have to talk about this, and it piggybacks on what you do. I tell people, well, I don't take them blood pressure meal. I didn't mess with my sex life. I say, well, okay. So you got that car out there you like? Yeah. And if you drive it real fast all the time, what happens? You just run it wide open. You're going to blow the engine, right? Think about your blood pressure. Okay, your blood vessels have to control that pressure, right? If you don't control it, it's going to rupture. Your brain, you're going to have a stroke. Your kidney's going to fail. I can't do nothing for you then. I mean, you got to take care of your entire body to stay healthy. I mean, to me, that's what this whole thing is about today. You know, just don't worry about one little thing. Take care of your whole body.
And I guess the other thing that I've seen as a primary care doctor, I'm trying to think when the foreskin is too tight.
Phimosis.
Phimosis.
Yeah.
Phimosis. So I get individuals coming in and they're kind of embarrassed about having phimosis. You can explain what that is and some simple treatments for that.
Yeah. Phimosis is a tightening of the foreskin where you can't retract it. If you can't retract the foreskin, you cannot practice good hygiene. I'm going to pick it back on that and say I see probably and diagnose 2 or 3 men a year presenting with that type of problems or recurrent infections of the foreskin as being diabetic. they'll come in with this chronic recurring infection of the foreskin, and I'll ask them, are you diabetic? Oh, no. You get a blood sugar of 600, okay? You know, when I say that, you know, they look at me like, why are you asking me am I diabetic? Because it's so common when your blood sugars are out of control, you can get this chronic recurring fungal infection of the foreskin. And a lot of ladies will get chronic recurring vaginitis, yeast vaginitis. So when these things are happening, you got to look for what's the cause, what's causation here. And most of the times they're borderline diabetics or they're overtly diabetics. Surgery is the main treatment for the phimosis, though. You know, we do the circumcisions, outpatient procedure. It puts you out of business for about 6 weeks. That's about all.
Now, are there any other common conditions that that we would want to get in earlier to see you for?
Well, I'm going to talk to the ladies real quick. So when you think of a urologist, you think of more of a male doctor. But I take care of a lot of ladies also, because ladies can have kidney stones, ladies can have urinary incontinence. And it's not that uncommon after, you know, having children, to have some stress incontinence or urge incontinence, and we treat a lot of this. And so there are medications out there for urgency and urge incontinence. There's a surgical procedure, a very simple procedure. It takes about 20 minutes for people who have stress incontinence. So for ladies, yeah, we have ladies in my practice. Probably 35% of my patients are ladies.
Okay. All right. And then your take-home message before we let you step down.
Well, don't be afraid to go to your doctor and get tested. You know, most people hate the rectal exam. I hate it too. But early detection for prostate cancer is the key for a better outcome. And I think you'll find this to be true with not only prostate cancer, but all cancers, okay? And with that...
no, wait, one last question. Bladder cancer.
Oh, my gosh.
Yeah. That was the one I forgot to ask you.
Bladder cancer is something, I'm going to be honest with you, I'd never seen bladder cancer in an African American until I moved to Louisiana. Okay. And then I started to realize why. We have, bladder cancers tend to be associated with cigarette smoking, a lot of toluenes, solvents that we have in the refineries around here. And I had never, and I had practiced in several places until I got here. So signs of bladder cancer usually is blood in your urine, what we call gross hematuria. Actually, you can actually see the blood. Or if you go to the doctor and they keep finding microscopic blood, you have to start worrying about bladder cancers, okay? Early on, bladder cancers can be treated with just simple resection of the tumor. And if it's not invading into the muscle, then that's all you need to do. Once you resect it, you go on to what we call surveillance. Unfortunately, if it becomes muscle invasive, then you're talking a total change of lifestyle, because you're talking removal of the bladder, okay, with having to have what we call an ileal conduit for urinary diversion. So the key is, anything out of the ordinary, don't hesitate to go see your doctor to be evaluated. Blood in your urine is not normal, okay?
And that's where the urgent cares come into play, because that happens a lot. You'll go to the urgent cares, you'll think you have a bladder infection, or you go in there with some abdominal pain, and they'll do a UA and they have the blood in there, and then but your primary care doctor never knows. But like you say, that's not normal. It should be worked up.
Exactly.
Or it'll get missed.
Yep. Thank y'all very much. Oh, sorry. Hey.
All right.
I'm a prostate cancer survivor, you know what I'm saying? And I had the robotic surgery and everything. And what I found out in the black community, and something that you said, 68% of black men are dying from prostate cancer. You are absolutely correct, because you're not the first person to tell that to me. But the problem is the reluctancy to have the exam. I had one guy that tell me, I say, because I'm an advocate for, look, man, go get checked. Man, I'm not going to let no man check me. I'm talking about, give me a prostate exam. I'd rather a woman. The reluctancy to have the exam is like I'm being violated. Man violated me and let me live. You understand? Violate me and let me live. But there's the reluctancy to have, you know, to do that. You know?
Most men tend to equate their manhood to the prostate, and they figure that if that's something going wrong, then I'm losing my manhood. But my thing is, if you're dying from prostate cancer, your man is gone anyways. So, I mean, all the treatments that we have to do to you may, especially at advanced stage diseases, you're out of the ball game anyways. So the key is stay healthy, get examined, get screened. If there's a problem, early detection makes a world of difference. That's the main thing today. Early detection makes a world of difference.
And the key is to be resilient.
Yeah.
You know what I'm saying? To be resilient.
This will be my last question. I'll let you go. As for we talked about staging with prostate cancer, that aggressive type is very rare, but in African American males, that aggressive type is that where it normally? Are we the ones that normally get that aggressive type?
The answer to that is no, but we tend to develop it earlier. The earlier the prostate cancer develops in younger men, it tends to be a more aggressive, a much more virulent disease. So to a point, yes, but usually the Gleason scores, I think they average out about the same. The average Gleason score that I'm going to see is probably Gleason score 7, which is an intermediate grade tumor. And like you said, every now and then you'll see a 9 or a 10, but those are kind of rare. But when you do see them, you have to be super aggressive with your treatment of those guys, because if you're not, prognosis is not good. Yes, sir.
But I haven't heard any symptoms of prostate cancer or signs.
Well, the problem is the symptoms of prostate cancer, the same symptoms you have with what we call benign prostatic hyperplasia, BPH. Signs of bladder outlet obstruction, slow urinary stream, hesitancy, things of this nature. You can't differentiate from cancer or BPH with just your symptoms. That's why it's important to get the PSAs, to get the rectal exam, to see if there's something different going on in the gland other than benign growth. We expect the prostate to grow. I mean, that's a part of aging. But you also have to make sure that it's not growing prostate cancer as well. Thank you all very much.
All right, thank you.